somebody who did an internal medicine residency and then did a fellowship in nephrology, which is the study and treatment of medical renal disease. So disorders of kidney function that are related to medical problems, meaning things that you would treat with medication, lifestyle changes, things of that nature. Urology, and there is some overlap between the two, but urology is a standalone specialty, and it's a surgical specialty. So urologists match to a urology residency training program and do that for their entire course of training. Right? So they're not internal medicine first and then do something else. They're urologists straight through. It's a 5-year residency program, and it's a surgical residency. So you're learning how to operate. So if somebody needs to go on dialysis, they're going to be taken care of by a nephrologist, right? They have medical renal disease. They have an intrinsic renal problem that is preventing their kidneys from working the way that they're supposed to, and they need support in filtering their blood, right? A urologist is the person who is going to be at least peripherally involved if the person needs, say, a kidney transplant. So nephrologists don't do kidney transplants. Most urologists don't do kidney transplants, although urologists can get training in transplant surgery, but you may very well see a urologist involved in doing, say, the living donor harvest. So if you have a patient who's donating or who needs a transplant, and say a family member or a friend has been found to be a match, and they're going to donate their kidney, then you may have a urologist that does that nephrectomy, that harvest of the kidney, so that it can then be implanted by transplant surgery. Okay? Urologists take care of things like kidney cancer. We take out kidney tumors. We take out whole kidneys. We take care of bladder cancer. We take care of testis cancer, prostate cancer, kidney stones, erectile dysfunction. Who here knows that you can do surgery for erectile dysfunction? I got one hand. So if Viagra fails and other associated medications for erectile dysfunction, we actually have implantable penile prosthetics that we can put in and allow an individual to literally inflate their penis when they want to have erection. Okay? It's a urologist that's going to put in those devices. We also implant artificial urinary sphincters. So if you have somebody who had prostate cancer, had their prostate removed, and now they've got urinary incontinence because their urinary sphincter is now incompetent due to surgery, we have artificial urinary sphincters that can be implanted so that they are able to be continent of their urine, and then they can deflate the cuff of that sphincter using a pump that's placed in the scrotum so that they can then urinate, and then it reinflates and they're continent of urine. Okay, so that's kind of your differences between nephrology and urology. So the way the course is set up, the first half is medical renal disease. So we're going to talk about nephrologic conditions with a little overlap. So one of the lectures in the first block is over cancers of the urinary tract, which are primarily going to be taken care of by a urologist or an oncologist if it's something that can't be treated surgically. And there's also, in today's lecture, there's a section on renal imaging, right? And that's going to be applicable to anybody who's looking at kidney issues. And then the second half is urology, which is primarily going to be surgical diseases of the urinary tract. Okay? If you have questions during the course of the lecture, please raise your hand. I tried very hard to, over the course of the last semester, get this in line with a non-urology audience, right? So in the past, when I've taught lessons like this, it's been to urology residents. I know you are not urology residents, okay? So if I say something and it sounds like I'm saying something that I expect you to already have a good grasp on and know, and you don't, chances are you don't. Raise your hand, okay? Ask me to elaborate. Hopefully that won't occur very often, but if I say something that sounds like it's common sense and you're like, hold on a second, I don't know what that means, raise your hand, okay, and ask the question. The other thing is I tend to wander around the room while I'm talking. If we get close to the 10-minute break time and I'm not near a clock, I'm not looking at my watch, just get my attention, okay? And we'll take a 10-minute break. Any questions for me before we dive into assessment kidney disease? Okay. All right. Okay, all right. Okay, so this is an overview of what we're going to talk about today. I cannot stress enough the importance of being able to look at urine under a microscope. We're going to spend quite a bit of time talking about urine examination. You may find yourself at some point in the future in a clinic or a forward deployed environment where you don't have the ability to send specimens to the lab for quick evaluation, but you may have a microscope. Looking at urine under a microscope is easy. You put a drop of it on a microscope slide and stick it on the microscope and look at it. You can glean a lot of information from urine just under a microscope. You don't necessarily need the lab to tell you what's going on. And if you have a dipstick, if you have the ability to just manually dip it yourself, great. If you have point of care testing that'll actually spit out a printout of what that dipstick means, even better. But being able to look at urine yourself is very important, so we'll talk about things you can find on urinalysis. We'll talk about renal function tests. Oh, real quick, this was an issue with the last senior class. Somebody tell me what definitive management means. I'm getting off on a little bit of a tangent, but this was something that they struggled with when it came to exams. What does definitive management mean?
It resolves the issue?
Solves the issue. So if you're talking about a surgical problem, just as an example, is definitive management something that you yourselves are going to be capable of? No. Okay, so if you see an exam question that says, what is the definitive management for this condition, don't be looking for what is it that I'm going to do for this patient. What is the final answer? So I'll give you just a general example. If somebody has a solid testis mass, which is cancer until proven otherwise, what's the definitive management for that mass?
Preferred.
Surgery. Okay? There will be no gotchas on my exams. Okay? And I know that there's a little bit of anxiety associated with classes that only have 2 tests, right? Okay? Don't worry about that. There's no gotchas. Everything that you need to answer the questions that you'll be presented with on my exams are in the question. There will be no requirement for leaps of logic. You're not going to be going, well, what's the third order eventuality that's occurring down the road with this patient? Everything you need to answer the questions that I'm going to give you on the exams will be in the question, and we will have a comprehensive review before each exam. If all you study before the exam is the review, it's your 80% solution. Okay? If you want to do better than 80%, you're going to need to study everything else. Okay? But the exam review that we'll do in the last lecture period before each exam is your 80% solution. Okay? Does that make everybody feel better? Good. Okay. All right. So your learning objectives for today: correctly analyze and interpret information pertaining to the genitourinary system obtained from various CERN studies, urinalysis reports. And then again, after we get through this, we'll talk about renal imaging. Okay. All All right, and there's your ELO for the imaging portion. All right, everybody remember what the kidneys are, right? I know it's been a few semesters since you had anatomy. I don't need to review the anatomy of the kidney. Okay, everybody remembers what a glomerulus is. Okay, that's the other thing. You're not going to have any like diagrams of a loop of Henle on the exam with an arrow pointing at it saying, is this the long loop? Is this the short loop? Is this the convoluted tubule? None of that. Okay, this is all practical application, things that you're actually going to need to know to take care of a patient in front of you. Okay. All right, but by way of quick review, nephron, you got tubules, you got a glomerulus, right? Here's a diagram you probably saw earlier in phase one. Again, just for review. You're not going to see this diagram on an exam question asking you to identify the pieces. Okay? So what do the kidneys do? They remove waste, help with fluid regulation, they help regulate blood pressure, right, via the renin-angiotensin system. Okay? And as a result, when things go bad to the kidneys, things can go bad in a lot of different places, which is why you'll find that in many medical conditions, the kidneys play a role in some form or fashion. Either they're affected by whatever's going on with the patient, or they're the underlying cause of whatever's going on with the patient. All right. Again, review. Kidneys secrete renin. They're also the source of erythropoietin and activated form of vitamin D. All right. So, in terms of evaluating the kidneys, how can you evaluate the kidneys for dysfunction? Well, you got laboratory tests and you got imaging. So we'll talk laboratory tests first, and then we'll get into imaging studies. Okay, so how many people in this room have given a urinalysis not for mandatory military drug evaluations? Who's gone to the doctor and they said, I need you to do a UA? Okay. How many of you, when you gave that UA, was it the first specimen in the morning? We got one, a couple more over here. Generally speaking, it's going to be whenever you showed up at the lab, right? Or at the clinic, if the clinic does their own urinalyses, like most urology clinics will do their own. So, first morning specimen preferred, but absolutely not mandatory under most circumstances. Okay. Obviously, it should be collected in a clean container. In a pinch, you don't necessarily have to do that. If you really need urine from somebody and you don't have a urinalysis cup, that's okay. Unless you're planning on culturing it. If you're going to do a urine culture, which you should always do if you suspect that the person has an infection, not necessarily a sexually transmitted infection, but if you suspect that they have a urinary tract infection, then you should always send urine for culture. Always, always, always. Doesn't matter what environment you're in. If you have the ability to send the culture, please send the culture. Whether you're in the emergency department or medicine clinic or wherever you may be, if you suspect somebody has a urinary tract infection, please send it for culture. And we'll talk more about why that's important later on. Okay. Methods of urine collection. Midstream urine is the primary method by which you're going to get urine collection from adults and adolescents. Why midstream? First of all, what's midstream? So it's not they just immediately start urinating in the cup, right? They start going and then pause and then commence urinating in cup until they've collected enough for the specimen. The reason that that's important is if there is incidental bacteria around the meatus or in the urethra that's not related to anything that's going on pathologically with the patient, theoretically, having the first part of the urinary stream go into the toilet will wash that incidental spurious bacteria away, and then what you end up collecting is what's actually causing a problem. Okay? So if somebody has a urinary tract infection, the bladder is going to be full of bacteria. right? And so flushing away whatever's around the meatus, even if somebody appropriately cleans before they do the urinalysis, swabs the glands of the penis or the urethral meatus, females, it doesn't get everything off, right? It can't. So theoretically, by doing a midstream urine catch, you're helping to minimize the likelihood of detecting skin flora, for example. Bag collection, not great for culture, not great for, well, it's not great for a lot of things, because collecting out of a bag that you've either got connected to a catheter or you've got taped on. So sometimes with neonates, they have bags that you can actually tape to the penis or tape to the vulva, and you just wait for the kid to pee. Is that sterile?
No.
Is it anywhere close to sterile? No. So you're not going to get great results with that, but sometimes that's what you're forced to do in that particular patient population. Bladder catheterization, if done appropriately, is like the gold standard for getting just what's in the urinary tract and not getting incidental flora from the skin. We don't want to catheterize everywhere. So do it if it's necessary. If you can't get urine from somebody and you need to order a straight cath, if it's a child, you can't get them to void on command, you've had a bag on them, they're not peeing, then you can do that. And if you absolutely have to, you can do suprapubic bladder aspiration. Like it says on the slide, only reliable way to obtain reliable urine specimen in neonates and young infants. It's not done all that often, but it is done. It's real easy to get to the bladder through the abdominal wall. So if you go about 2 centimeters up from the pubis, what's behind that?
Bladder.
Just the bladder. As long as the bladder is full. If the patient has a full bladder, there's nothing beyond that point. You're not going to hit anything else. Now, if it's somebody who's had prior abdominal surgery, all bets are off. And that's something you need to take into consideration before you consider doing a suprapubic bladder aspiration. But if they don't have any prior history of abdominal surgery and their bladder's full, 2 centimeters above the pubis, straight in a kid, an infant, an 18 gauge needle. I'm not saying you should use an 18 gauge needle, but I'm saying your standard 18 gauge needle that you might use to draw up medication out of a medication vial is long enough to get to the bladder, unless they're really bad. But most of the time, if you're going to do a suprapubic bladder aspiration, you're going to use something more akin to like a spinal needle to make sure you've got enough depth. All right, so who's seen these UA bottles before? Right, so these are, it's real easy to use. If you have a pool, or if you've ever taken care of a pool and you've tested the chemical makeup of your pool, like your chlorine concentration and things like that, it's exactly the same. You get the urine specimen, you get the dipstick, and you follow the instructions on the bottle. It varies from company to company that manufactures these, and say let it sit for this amount of time, and then all you do is you compare the dipstick strip to the color change boxes on the bottle, and it'll tell you roughly what range you've got of each of those constituent components. Okay? So a word of caution, and we'll talk more about this a little bit later, but if you're dependent on color change to tell you what's in the urine because you're using a dipstick, or this applies also to the automated machines that you then put the dipstick in and it reads the color change for you, what do you have to be cautious about? Louder? One more time. So, I mean, yeah, you need to follow the instructions for how long it takes and make sure that the color changes happen. But I'll give you a specific example. Nitrites. Nitrites are a sign of infection, right? Nitrites are a sign that there's bacterial metabolism. It might as well be Monday. Metabolism taking place in urine, right? Certain bacteria metabolize the constituents of urine and produce nitrites as a side effect of their metabolism. Right? What color does the box turn to indicate that there are nitrites present?
Shade of.
Sort of guess what I'm thinking. It's red, orangish red. What else turns urine red or orangish red. So hematuria will do it. Are there any medications that turn urine orange? Right, so azo is available over the counter. It's also, you can also prescribe it, phenazopyridine. It's a bladder analgesic. It turns the urine orange. So if you have someone who thinks they have a urinary tract infection and they went to their local Walgreens and bought a bottle of azo, and they do a urinalysis by point of care testing, is it going to be orange?
Yeah.
Yes. Does that mean they have a urinary tract infection? No. Because it's all based on just a change in the color. So these are things you need to keep in mind. There's other things that can do it. Rifampin, which is an antibiotic, will turn urine orange as well. So just something to keep in mind. It's always a good idea, if there's any question at all about the patient's clinical presentation, you have the ability to actually look at the specimen they gave, go look at it. Because if it's bright orange, an unnatural shade of orange, chances are that there's something spurious going on. All right, so things that you'll see referenced on urinalysis reports, or if you're just looking at the urine yourself, color. Color can tell you things, but it's not a slam dunk. Again, there's things that can turn urine colors that are not natural, but aren't necessarily an indication that there's something pathologic. Who's heard of methylene blue? Okay, I got a couple hands up. It's been in sort of the zeitgeist, if you will. Lately, people say that taking methylene blue can be good for lots of different ailments. I don't know how accurate any of that is, but methylene blue is used in certain situations in the operating room. There used to be a bladder analgesic called Proced DS that's not available anymore that had methylene blue as a component. What color do you think it turns urine?
Blue.
Blue! So being able to look at somebody's urine and say, well, that's not normal, is helpful. Turbidity, again, not a slam dunk for anything. A person's urine may be cloudy for a lot of different reasons. Just because it's cloudy doesn't necessarily mean there's something wrong with it. And odor. Again, if somebody's urine smells bad, there may be something going on, but there may not. Who here has the asparagine gene? And when they eat asparagus, their urine smells like nasty digested asparagus? Me? All right. So just because somebody's urine smells bad doesn't necessarily mean there's something wrong with it, but it can. In the Middle Ages, physicians used to actually taste their patient's urine, because if it was sweet, then
Diabetes.
they're probably diabetic, right? Not that they really had an understanding of what diabetes was back in the 1400s, but they knew it wasn't supposed to be sweet. Now, am I saying that you should be tasting your patient's urine? Absolutely not. Don't do that. That's a terrible idea. But in the absence of other diagnostic methods, these are things that medical practitioners did in antiquity to help figure out what was going on with the patient. All right, so your specific gravity. Most of the time, the specific gravity of the patient's urine isn't going to be that much of a concern. It's not going to be something that you're going to focus on unless you suspect that they are fluid overloaded, maybe they have water intoxication, or SIADH. You know, if their urine is extremely dilute, then you know that's going to jump out at you. But most of the time, specific gravity is not really a concern. And your urinary pH, it can be acidic, it can be alkaline. It depends on what the patient has been eating, drinking, and then certain bacteria can cause changes in urinary pH as well. So things that are like urease-producing organisms like Ureaplasma urinalyticum, Proteus mirabilis, these alkalinize the urine and can cause certain types of kidney stones to form as a result of the alkalinization of the urine and the things that they're breaking down. We'll talk more about that later. But the point is that pH in and of itself won't necessarily tell you everything you need to know, but taking the patient's entire picture and their entire clinical presentation, the urinary pH can be helpful. Examples like it says on the slide, like somebody in diabetic ketoacidosis, if they have a chronic diarrhea, that sort of thing, can also affect their urinary pH. All right, protein. Is it normal to have protein in the urine? Yes. There are trace amounts of protein in the form of tan-horsefall protein in the urine. Albumin you should see in large quantities. Okay, so having a little bit of protein per day is not necessarily pathological. Now, if you've got somebody who's dumping more than 3.5 grams of protein per day in their urine, now you're talking about like nephrotic syndromes, right? We'll talk more about those later. But having a little bit of protein is not necessarily a bad thing. Glucose should always be negative. Should always be negative. Now, there are newer diabetic medications on the market. Jardiance is one of them that actually cause patients to dump glucose in their urine as a mechanism for keeping their blood sugar down. So you need to be aware of what your patients are taking, because it might actually be quote unquote normal for them to have glucose in their urine. But if they don't take any meds, excuse me, and they've got positive glucose on their urinalysis, there's a problem. They're almost certainly diabetic. It's not normal to dump glucose under normal circumstances in the urine. And it's bad because the glomerulus isn't designed to filter glucose, and long-term filtering of glucose damages the glomerulus, which is why people with uncontrolled diabetes often have problems with renal dysfunction and long-term renal failure. Okay, so I mentioned nephrotic syndrome, talking about massive protein being dumped in the urine. We'll talk in more detail about that when we talk about nephrotic syndromes specifically. Just know that you can see protein in the urine. It's not necessarily bad. Lots of protein, nephrotic syndrome. And I'll even go ahead and tell you one of the mnemonic devices that they taught us when I was in medical school to help you remember the difference between nephrotic and nephritic. So nephrotic syndromes are always characterized by large quantities of protein. The way you remember that is nephrotic has an O in it. The O has a giant hole, which allows large protein molecules to get through. Okay? So just remember nephrotic, lots of protein, and the mnemonic is the big hole in the O lets the protein through. Okay? All right. Ketones generally should be negative, unless you have somebody who is in ketoacidosis or is maybe on a ketosis-producing diet. Then you may see ketones in the urine. In fact, and I don't know how many of you have ever done things like Atkins or other ketosis-producing dietary regimens, but they sell dipsticks over the counter that you can use just to check your urine for ketones to let you know if you're in ketosis. So if you have somebody who's on a high-protein diet, then they may, and low carbs, then they may have ketones in the urine. Blood in the urine is never normal. It's never normal. Blood in the urine can be caused by infections. Blood in the urine can be caused by medical renal disease. There are conditions that cause people to lose red blood cells through the glomerulus. Blood in the urine can be caused by cancer. So from my perspective as a urologist, blood in the urine is cancer until proven otherwise, because that's what I deal with, right? And that's a pants pearl for you right there, and you'll see this in later lectures, okay? A long-term smoker with hematuria, whether it's microscopic or gross, particularly if they're male, it's cancer until proven otherwise. Okay, so remember that. That's a high yield thing that shows up on lots of board certification exams and licensing exams in the past. But the source of the blood is really what you're getting after when you find blood in the urine is to figure out where it's coming from, because like I said, it could be medical renal disease, it could be cancer, it could be a kidney stone, it could be urinary tract infection, but there shouldn't be blood in the urine under normal circumstances. All All right, urobilinogen. What's going to cause elevated urobilinogen and bilirubin? I know it's on the slide, but give me some examples. These are like general examples. So you might see it in sickle. Yeah, anything that's causing lysis of blood cells, you might see it there. So basically, anything that causes hepatocellular dysfunction. So if you have somebody who's in liver failure, if you have somebody, like it says, biliary obstruction. So if you've got somebody who's got a gallstone that's blocking their common bile duct, then you may see increases here. You're not going to know exactly what's going on with the patient just because they have high levels of urobilinogen. It's going to push you down towards what else is going on with this person. Now, obviously, if somebody's in liver failure, they're going to have other things that are going to be indicating to you there's something going on. They may have massive ascites, they may have jaundice, which is also a result of their production of urobilinogen. All right, leukocytesterase. Another indicator that somebody might have a urinary tract infection is the presence of leukocytesterase in and of itself a slam dunk that somebody has a urinary tract infection. No, it just means that there are leukocytes somewhere near their urine. Now this is particularly a problem for female patients because doing a clean catch urine specimen is nearly impossible because of the anatomic construction of the female urinary tract, right? The urethral meatus is recessed and the labia are in the way, right? What is a normal thing to find in vaginal secretions?
Leukocytes.
Leukocytes! So if you have a female patient who has positive leukocytesterase on their urinalysis, it does not mean that they have a urinary tract infection. This is why it's so important to see urine culture. What is a very, very common urinary complaint that can mimic the same signs and symptoms of urinary tract infection and is particularly prevalent in women?
Dehydration.
They like to advertise medications for this condition on TV all the time. I haven't seen as many lately, but there used to be quite a few of them. Anybody remember a commercial that had like a cartoon bladder walking down the street? Anybody? No? Okay. Overactive bladder. So if somebody has overactive bladder, what are the signs and symptoms of overactive bladder? Urinary frequency, urgency. I gotta go all the time. After I've just gone, it feels like I still need to go again. What are the signs and symptoms of your urinary tract infection? Urinary urgency, frequency. I feel like I gotta go all the time, even though I just went. So if you have a female patient, and male patients can have OAB too. If you have a female patient who has those symptoms, and they've got positive leukocytesterase, do they have a urinary tract infection? I don't know. Do they have OAB? I don't know. They need further evaluation. Always send urine for culture if infection is in your differential, because if they have an infection, it'll grow. And urine cultures come back fast because bacteria love urine, with a few exceptions. If you suspect somebody has genitourinary TB, that urine culture is going to cook for 6 weeks before they give you a final negative result, because mycobacterium take forever to grow. They have to grow them on special plates. That takes a long time. But for your standard common organisms that cause urinary tract infections, like E. coli being the most common, E. coli loves urine. It grows like crazy. You will have a final urine culture result with the type of organism and its antibiotic sensitivities within 48 to 72 hours. Now, if you're working in a government facility that shuts down over the weekend, it might take longer, depending upon when their urine made it to the lab. But from a functional standpoint, you'll have urine culture results in 48 to 72 hours. And they usually give you interim updates. So at 24 hours, if there's something growing, but they can't tell you what it is yet or what it's sensitive to, you'll at least get an interim result in the system that says, we got bacteria growing. And then if you already gave the patient something empiric because you really strongly suspected they had a urinary tract infection, and the culture results finally come back and you find out, oops, this bacteria is not sensitive to what I gave them, then you can adjust fire. Call the patient, say, hey, I need to change your antibiotics, right? You can't do that if you didn't send the culture. Always send the urine. Urine microscopy, as I mentioned at the beginning, is very, very useful because if you don't have access to a lab, but you do have access to a microscope, you can learn a lot about what's going on with somebody just by looking at their urine. You can see red blood cells, and you can see crystals if they've got any sort of urinary crystal, whether it's calcium oxalate or struvite, cysteine, all of those things are visible. And you may not be able to identify it. You may not be able to say, oh, that's a cysteine crystal. But you're going to be able to see that there's something that looks like a tiny diamond in their urine, and you're going to say, well, that's not supposed to be there. Red blood cells, are they red when you look at them on microscopy without the benefit of staining? No, but everybody knows what a red blood cell looks like, right? Corpuscular, looks like a donut that didn't have the hole quite punched out in the middle. You can see that. Things you may see in urinary sediment: red blood cells, white blood cells, casts. So I know what it says here for casts, but what is a cast? Okay, let me back up for a second. Forget we're talking about kidneys right now. If I told you to make a cast of something, what am I telling you to do? Not cast someone because they have a broken bone, but to make a cast of something. Imprinting, molding. Okay, so what do you think a renal cast is? So it's a tubule. You're right. So if somebody has something going on in their kidney itself, and cells are being sloughed, and they're getting bogged down in the tubules, in the renal tubules, those cells will get compacted together, and they'll stay compacted together when they finally make it out through the calyx and into the collecting system, and they come out in the urine, and you can see that under a microscope. And I have pictures later, but you'll see it looks like somebody took plaster of Paris and made a cast of the inside of the tubule, and that will tell you that there's something going on in the filtration system, and then it's a matter of determining what types of cells they are to figure out, is it a white blood cell cast? Is it a renal epithelial cast? Is it a red blood cell cast? But it can tell you more about what's going on in somebody's kidneys. Talked about crystals already, and then of course organisms, other cells. Can you see sperm on your analysis? It's on the slide, right? Yes, you can. So spermatozoa may be present in male patients who've had a transurethral resection of the prostate because they suffer from retrograde ejaculation. People who are on alpha blockers have retrograde ejaculation, so their ejaculate goes backwards instead of out, and so they end up with sperm. Or if somebody just recently had intercourse. So it's not abnormal to see sperm on your analysis. Squamous epithelial cells. If you have somebody do your analysis for you, whether you're looking at it yourself or you send it to the lab, and it comes back with squamous epithelial cells, can you trust the results of a urine culture from that specimen? No, it's contaminated. You need to do it again. This is why a clean catch is so important. And obviously, as I've said several times before, doing a clean catch is challenging for certain patient populations, neonates, infants, females. But don't hang your hat on the urinalysis that has squamous epithelial cells, because the results are questionable at best. Now, if you have somebody who has signs and symptoms of urinary tract infection, and their urine culture comes back with greater than 100,000 colony-forming Haemophilus E. coli, and their urinalysis had squamous epithelial cells on it, you're still going to treat that patient. Having a few squames contaminating the specimen is not going to alter the fact that they had a pathologically positive urine culture. But you have to take it with a grain of salt. So transitional epithelial cells, urothelial cells, same thing, different terminology. When I started my training, it was transitional epithelium. TCC, transitional cell carcinoma. That terminology is being phased out in favor of urothelium. But if you see either of them, they mean the same thing. It's the cells that line the bladder, the ureters, and the collecting system of the kidney, the renal calyces. And the presence of urothelial cells in and of itself is not necessarily a sign that there's something abnormal going on, but if there's large quantities of them, and if they don't look normal to the folks in the lab, it's not something you're going to be able to tell just under a microscope if you're looking at it yourself. But if folks in the lab say, hey, there's a lot of urothelial cells, and they don't look quite right, they've got high numbers of mitotic bodies, things like that, then that's potentially an indication that a patient has a urothelial cancer somewhere in their urinary tract. And because the urothelial cells are present along that entire course that I just described, collecting system, ureter, bladder, that cancer could be anywhere in that. So urothelial carcinoma can arise from anywhere that there is urothelial cells present, which is that entire course. Please don't order a urine cytologist. Just don't do it. If you suspect that a patient has a urothelial cancer, just send them to a urologist. Okay? Urine cytologies muddy the water. We generally don't order them all that much anymore. There are certain specific situations in which we follow patients, but you can cause a lot of anxiety for a patient by ordering a urine cytology and having it come back with atypia. What does atypia mean? They don't look quite right. Does it mean they have cancer? Not
Maybe.
necessarily. Could they? Yes. Just don't order urine cytologies. Now, you may see questions that have urine cytology like on chance and other exams that you may take. I'm not saying that it's never the right answer, but I'm saying in practical application in real life, if you have a patient that you think needs a urine cytology, just send them to urology. Okay? Don't take that on. The other big issue with this nowadays with EMRs, is there anything that stops a patient from looking at their lab results before they've been reviewed by a healthcare provider? No, there's no gate. So there's no way to guarantee that you're going to see results and get a hold of a patient before they read them themselves. Like it drives me crazy. If I do a prostate biopsy on somebody and it comes back positive for prostate cancer, there is a chance that the patient is going to see that pathology report before I have. And that's a problem, because then you've got to do damage control and talk them down off a ledge. So just don't order urine cytologists. It's a problem. Okay, so renal tubular epithelial cells. This is what they look like. No, you're not going to have an exam question that shows the slide and says, what are these? Okay. But this is important in that, like it says on the slide, you may see these in patients that have had some sort of renal tubular injury. Anything that causes tubular necrosis, whether it's pharmaceutically induced or somebody with rhabdo. If you've got somebody who's got rhabdomyolysis, then you're probably going to see tubular necrosis, and you'll see renal tubular epithelial cells in their urine, which can also form casts, right? If enough of them are sloughing and they're getting hung up in the tubules before they come out, then you'll see this is another cell that can show up as cast. All right, so hematuria. Like I said, blood in the urine is never normal. Greater than 3 red blood cells per high-powered field on microscopy. Should get your antenna out. You should go, what's going on here? Common confounding factor? Females that are menstruating. So if you're going to collect a urinalysis on a woman of childbearing age, it's helpful to know whether or not they are currently menstruating. And if they are, you may want to have them wait before they give that urinalysis, just because it's gonna muddy the water. Sometimes that's not an option. You got to get urine because you suspect they have pylo, or febrile, or they're unstable, and they're menstruating. But if it's at all possible to get that confounding factor out of the way, you should do that. But again, red blood cells, from my perspective, this might be cancer. Patients that get referred to urologists for blood in the urine is because somebody somewhere thought that this was a potential sign of a malignancy, and that's why they got sent to us. But as I mentioned, knowing where the blood cells came from is something that you can see on microscopy, which is another reason why it's good to look at the urine yourself if you have the ability. But the lab should tell you these things. They should tell you, yeah, we saw 5 red blood cells for high field of magnification, and they were normal appearing, or they were dysmorphic. So they weren't the right shape, right? That's a typo. I thought I caught them all, but apparently I didn't. Crenellated. Crenellated. Who can tell me what crenellated means? Think of a castle. Think of the battlements at the top of the castle wall. So it's sort of a scalloped appearance. Now, are red blood cells that appear crenellated, does that mean that they look like somebody built them in Minecraft? Like they're all squared off and blocky? No, but they'll have sort of a scalloped, ridged appearance to the side. And that can be caused by concentrated urine. You can also see crenellated red blood cells in red blood cells that were squeezed out through the wall of the glomerulus. So they could be described as dysmorphic. They might be described as crenellated. But that means that the problem is intrinsic to the kidney. It's not a problem that occurred past the kidney. So if somebody's got blood in the urine because they've got kidney stone or they've got cancer, it's because something is actively bleeding into the urine, as opposed to the blood cells are being pushed out through a glomerulus. Okay. Let's go ahead and take a 10-minute break. 1 or 2, maybe. But if they've got greater than 5 for high powered field, then there's probably something going on there. Again, if you're looking at the urine yourself under a microscope, you're not necessarily going to be able to differentiate between neutrophils and eosinophils. The lab and they'll tell you. And what type of white blood cells present can be indicative of what's going on. So if somebody has allergic interstitial nephritis, or they've got nephritis due to a pharmacologic cause, so proton pump inhibitors are a common cause of interstitial nephritis, then you may see eosinophils in the urine. And then, obviously, infection or inflammation of other sorts can cause white blood cells to be present in the urine. Strictures in and of themselves don't really cause pyuria, but if you have a stricture that is a result of a chronic infectious process, like I mentioned TB earlier, right? So tuberculosis can cause strictures in the urinary tract, gonococcal disease, things of that nature. But just the presence of a stricture. So some people develop strictures in the ureters or in the urethra idiopathically, where there's no underlying cause. Just having a stricture doesn't necessarily cause pyuria. Neoplasms. Urinary neoplasms. Neoplasms that arise from the urinary tract itself aren't necessarily going to cause pyuria, but is it possible to have lymphoma in the urinary tract? Is it possible for somebody who has lymphocytic leukemia to have white blood cells that are coming out in their urine? Yes. So when we say neoplasms, we're not necessarily talking about genitourinary neoplasms, just neoplasms in general. And then sterile pyuria. So you see somebody in clinic, do your analysis, a microscopy comes back with large numbers of white blood cells, they culture it, nothing grows, sterile pyuria. And that can be a result of a lot of different things. All right, so we talked about casts. This is a cast, okay? Specifically a red blood cell cast. But any cells that get hung up in the tubules and get compacted together and then come out and form casts. And that's what a cast is. That's a white cell cast. Like it says on the slide, can be indicative of acute pyelonephritis. So somebody's got a bad kidney infection, and there's lots of white blood cells that are being funneled to the area to try to fight off that infection, and they're getting excreted, forcing their way through the glomerulus, and they get impacted or compacted in the collecting system, or in the tubules before they get to the collecting system, and then you can have white blood cell casts. And then epithelial cell casts, like we talked about, tubular necrosis. So if you have somebody who, just as an example, took a whole bottle of ibuprofen, they're going to have other problems besides acute tubular necrosis, but they're probably also going to have acute tubular necrosis. And so you may see epithelial cell casts in their urine, if their kidneys are even making urine at that point. And then hyaline or fatty casts. So it may not be readily apparent in the picture, but if you can visualize a drop of vegetable oil on the surface of a puddle of water, like in a cooking pan, that's kind of what that looks like, right? So that's fatty material in water, essentially, and those can form casts in the tubules as well. And then in nephrotic syndrome, you can see something called oval fat bodies, and that's why these fatty casts are strongly associated with nephrotic syndrome. We'll talk more about oval fat bodies. Okay, so crystals, we'll talk a lot more about crystals later on, especially when we talk about kidney stones. Just know that crystals can be present in urine. It's not necessarily a sign that there's something going on, but if you have somebody who has a history of kidney stones, then having visible crystals in the urine on microscopy is a sign that maybe there needs to be some adjustment made to their treatment regimen to help prevent them from making more stones in the future. Stones can also be caused by bacterial metabolism, as I mentioned before. So struvite, which is also sometimes referred to as triple phosphate, ammonium triple phosphate, same thing. Those crystals don't just form like spontaneously. There has to be something there that's causing them to form. Urease producing organisms. Cystine stones are usually a result of some inborn defect of metabolism, like homocystinuria. So you see cystine stones in children who are born with homocystinuria, and adults too who have grown up with it. Uric acid stones, usually you see in people with metabolic syndrome, diabetes, people on high protein diets. And again, all of these crystals can precipitate and conglomerate and form actual stones that can be clinically significant. And of course, bacteria. Is normal urine sterile?
Depends on the way of getting it. In the bladder, yes.
So traditional teaching is that normal urine is sterile. It's actually probably not. But the things that would be found in urine, in normal urine, aren't considered pathologic, and they aren't things that they're cultured for, and they're not things that they look for. So the current thinking is that the normal urine is not truly sterile. You shouldn't wash wounds with it. But it's not filled with pathologic organisms. Generally speaking, if you look at normal urine under a microscope, you're not going to see bacteria, which could, and it doesn't necessarily mean that there's something going on. Just know that normal urine, well, the traditional teaching is that normal urine is sterile. It's not truly sterile, but it shouldn't be full. You know, if it looks like this, lots of little bacteria, that's not normal. Under any circumstances. And again, culture urine, please. If you suspect somebody has an infection, do a culture. Yeasts, this is becoming more and more of a problem. I don't know if anybody has been keeping up with the latest developments in infectious disease around the world, but there is a strain of Candida. It was originally isolated in Japan, I think, found in the ear canal of a patient, so they named it Candida auris, A-U-R-I-S. It is highly, highly resistant to medication, and it's now been found in 60 countries around the world, including the United States. It is driving a push to make new pharmaceutical agents to treat fungus, because it is bad news. But like most yeasts, it's not something that you typically find in people with normal immune systems. So the places that you're mostly going to see people with yeast in their urine are going to be elderly patients who don't have good, strong immune systems. Anybody with any form of immune compromise, whether it's because they've got HIV that's not poorly controlled, or they're on immunosuppressants because they have an organ transplant of some sort, or they're on something to suppress their own immune system because they have some sort of autoimmune disorder like lupus. Obviously, people who have taken antibiotics recently. So you'll see, particularly female patients, you will see that you treat them for something like, say, a urinary tract infection, and then the next week they get a really bad yeast infection, and it's because you've messed with their normal flora. Patients who have learned that they are prone to that will usually be very vocal about it, and will say, if you're going to give me antibiotics for a urinary tract infection, please give me doses of ibuprofen also. You should just listen to them and do that, because they know. Diabetic patients, obviously, if they're poorly controlled, their immune system doesn't work as well as it's supposed to, and yeast love sugar, which is why we put yeast and sugar in alcohol, to make alcohol, or to leaven bread. Anybody who has an indwelling catheter, actually it doesn't even have to be indwelling. So if you have a patient who has a poorly functioning bladder and they do clean intermittent catheterization, their urine is always going to be ugly. If they have an indwelling catheter, their urine's going to look filthy. After 48 hours of having a Foley catheter in the bladder, the catheter will have developed biofilm, and there will be bacteria in the urine, guaranteed. Now, they're not necessarily going to have yeast after 48 hours, but they will have bacteria. And this is why it's so important to get catheters out of patients in the hospital as soon as it is feasible. Obviously, there's certain situations where we have to leave a catheter in somebody for an extended period of time. Catheters are sort of a double-edged sword. So, what do you think was the most common cause of death in spinal cord patients up until the 1970s?
Bladder infection?
Not catheters.
Was it bladder infection?
Not bladder infections, but you're on the right track. What are we talking about right now? What is this class? Or what is this lecture? So it was renal failure. The most common cause of death in spinal cord patients prior to the 1970s was renal failure. Because when somebody has a spinal cord injury, there's only a few things that can happen to their bladder. Their bladder either turns into a tight little contracted knot that doesn't hold much, and what it does hold is high pressure. They can have a completely incompetent urinary sphincter and they just leak urine all the time. Or they can end up with a big dilated water bag of a bladder that's low pressure. So leaky sphincter and high capacity, low pressure bladder is renal protective, because it's not allowing any pressure to be exerted on the kidneys via the ureters. But if they have a high pressure bladder and they have a competent sphincter, now you've got pressure on the kidneys, and over time that causes damage and ultimately renal failure. So what killed spinal cord patients prior to the 1970s was renal failure. So what happened in the 1970s? Well, somebody got the bright idea to start teaching spinal cord patients how to catheterize themselves. So instead of having to have an indwelling catheter all the time, which most of them didn't want to deal with, still don't want to deal with it, having an indwelling catheter is not fun. Whether you have an intact nervous system or not, but being able to put a catheter into their own bladder every 4 to 6 hours while they're awake and drain their bladder, now they don't have to worry about a high pressure storage. So let me back up for a second. Even in somebody with a large volume bladder that's low pressure, if they can't volitionally void, how does the urine get out of their bladder? So eventually there will be pressure, but the question is, where does the pressure have its effect first? Is it on the sphincter or is it on the ureters? Well, it depends. It varies from patient to patient. So if the first place to leak is the sphincter, then their kidneys are probably going to be fine. But if the first place to start having reflux, in this case, is the ureters, now you've got pressure building up on the kidneys. So being able to drain the bladder on their own, increased life expectancy for spinal cord patients, particularly people born with spina bifida, because they're dealing with from birth. That's why prior to the 1970s, you didn't see a lot of spina bifida kids making it to adulthood. Their kidneys were failing. And now they live a perfectly normal lifespan. But having a catheter in all the time causes all sorts of problems. Crystals form on it, so you get like this eggshelling in the bladder when you take the balloon down. When the balloon on the catheter goes down, whatever mineralization has occurred on the bladder, or on the balloon in the bladder, breaks free, and then they have these eggshell-like structures that can then be a infection. After 48 hours, you've got bacteria in their urine. So you don't want to leave catheters in people any longer than you have to. And then obviously post-surgical patients are at increased risk for yeast as well. Oval fat bodies, mentioned this before. Under polarized light, like it says, they have a Maltese cross appearance. So what you're seeing here, remember that fatty cast we saw a few slides back? This is a fatty cast. You can see the shape, right? The tubule shape, but it's under polarized light, and so those are the fat bodies, and that's that characteristic Maltese cross. You may see a question about oval fat bodies and nephrotic syndrome on the exam, maybe, possibly, could happen. Remember, oval fat bodies and nephrotic syndrome and the association. All right, I've talked about urine cultures ad nauseum. I'm not going to waste time on this. Just know that 100,000 colony-forming units is considered a positive urine culture. If it's less than that, but the patient is strongly symptomatic, then you can assume that that culture is also positive. And like it says on the slide, it's not necessarily a reflexive order. So sometimes when you order urine cultures in an electronic medical record system, it will have a reflex culture built into it. So you order urinalysis, and the lab will automatically culture it if the urinalysis looks abnormal. Just order a separate urinalysis and a culture. If you suspect somebody has an infection, order urinalysis, order a culture. Then you don't have to worry about whether or not the lab runs the culture. The other thing is it possible for somebody to have what appears to be a completely normal urinalysis and still have a urinary tract infection?
Yes.
It is possible. And if you've ordered it with a reflex order and the urinalysis looks normal, are they going to do the culture?
No.
No. So just order urinalysis and a culture. Okay, so some definitions. Azotemia, elevation of blood urea nitrogen, or DUN, and creatinine levels. So if you hear somebody saying that a patient is azotemic, it means that their DUN and creatinine is elevated. Okay. Uremia, severely elevated concentrations of nitrogenous end products of protein metabolism. So if somebody has renal failure, particularly if they have renal failure and liver failure, then you'll hear people talk about uremic. The patient is uremic, they have uremic syndrome. They can end up with what's called uremic frost. So if their uremia is bad enough, they can actually get crystals that form on the skin. And they look like Jack Frost. They look like somebody dusted them with snow. It's pretty rare nowadays, but you can still see it. And then end-stage renal disease, refers to kidney failure treated by dialysis or transplantation. So, can a person have end-stage renal disease and not be on dialysis?
Yes.
Yes, they can. They may not have made it to that point yet. Just having end-stage renal disease does not automatically mean that the patient is started on dialysis, although they're headed in that direction. And they're probably being counseled for it. Technically speaking, somebody who has had a renal transplant that works and it's functioning fine and it's filtering their blood still has a diagnosis of end-stage renal disease because they needed a transplant. So they still have it, but they also have a functioning transplant kidney. Okay, so BUN, hopefully you guys have seen these labs before. Hopefully I don't need to get too far in depth in describing them. But BUN is a product of protein metabolism. So is creatinine, more so a product of muscle metabolism than strictly protein metabolism. There's no issue with people taking exogenous creatine as a dietary supplement and for working out, that sort of thing. Just know that people who take creatine may have elevated creatinine. The other thing that you need to know is that if you have someone who is particularly muscular, gender doesn't matter, particularly muscular, their baseline creatinine is going to be higher. So just because they have, say, a creatinine of 1.3, 1.4, they may have normal renal function. I'll give you a specific example just to illustrate the point. When I was on faculty at BAMC, my first assignment out of residency, there was a guy who worked in the IT department over there, a civilian, who was one of the largest human beings I've ever seen with my own two eyes in person. And I'm talking about in terms of muscle mass. He was enormous. Like this guy, when he wasn't at work, he was at the gym. He was huge, okay? He had a family member in another state who needed a kidney transplant. And he wanted to find out if he was a close enough genetic match to donate a kidney. And this transplant center on the other side of the country asked for him to get lab work done and send it. And when they saw his creatinine, they're like, you probably are going to need a kidney transplant at some point. Your creatinine is really high. And he was a relatively young guy. He was in his early 40s. And he was like, no, you don't understand. I'm huge. And they were like, we don't believe you.
Pixar didn't happen.
We want to see you. And so he actually had to send the transplant center a photograph of himself, and they were like, oh, you are huge. Now, as it turns out, he wasn't a close enough genetic match. He wasn't able to donate one of his kidneys to a family member. But just know that just because somebody has an elevated creatinine, it doesn't, especially in our patient population, we have a lot of young, healthy, fit gym rats in our patient population. Just because their creatinine is elevated doesn't necessarily mean there's something abnormal going on. But that means you need to look at the patient and do a correlation, right? Does this person look like their creatinine should be higher because of their bulk? If you have a small, thin, non-muscular person, let's put it on the opposite end of the spectrum. If you have a fragile little old lady or little old man, we all lose muscle mass as we get older, right? So if your muscle mass goes down, your creatinine should also go down. So if you have a small, not very muscular, frail person and the creatinine is normal, say it's 1.0, is it actually probably elevated? Potentially, might need to look into that. So creatinine is a surrogate for renal function. Creatinine does not actually tell you how well somebody's kidneys are functioning. It is a surrogate for renal function. The reason we use creatinine is because it's easy to measure, it's cheap, and it only comes out in two places. Well, that's not exactly right. It only comes out in one, but it's detectable in two. Creatinine comes out in urine. So if you check a creatinine level on urine, it's astronomical, which is one of the reasons why we use creatinine as a test on surgical drains. If we've done surgery on the urinary tract and we want to know if our anastomosis, whatever we've sewn back together again, is good and they're not leaking urine, we'll take the fluid that comes out of their JP drain and send it to the lab for creatinine level. And if it's the same as serum, they're not leaking. If it's 500, that means there's urine somewhere in there that's not supposed to be there. But because it's only excreted in urine, you can still detect it in the blood, and it tells you how well the kidneys are dumping creatinine in the urine. So it's a surrogate, but it doesn't actually tell you how well the kidneys are functioning. There are other tests that can tell you better directly how kidneys are functioning. Yes?
I was curious, if you had a patient who is supplementing creatine, would they also have an elevated creatinine?
Yeah, they can potentially,
Okay.
depending on how much they're taking in. And somebody who's on a really high protein diet is also potentially going to have an elevated creatinine level. All right, so V and creatinine ratio, you're not going to be asked to calculate this on the exam, but do know how to do this because this is something that you're going to use in clinical practice. You look at a patient's creatinine ratio to see are they dehydrated or they're not dehydrated. Dehydration can be a reason for somebody to have elevated kidney function numbers, and if you hydrate them, they'll get better. But if their V and creatinine ratio doesn't line up with a dehydration picture, then they may actually have intrinsic renal disease. And like it says here at the bottom, pay attention to the actual values. 100 to 10 is the same as 10 to 1, but it's not normal, right? Because to get to that ratio, you have to have higher baseline levels. So just know that you can't just look at the ratio and say, oh, that's fine. You got to know what the numbers were that went into the ratio. All right, so glomerular function tests. So there's been a lot of formulas that have been calculated over the years to give you an idea of how somebody's glomerular function is. So you may have heard the term the Cockcroft-Gault equation is one way to calculate glomerular filtration rate. Again, these are all just calculations. They're surrogates. It doesn't actually tell you how well a person's renal function is doing. In the past, they used to, on laboratory results, would give you an estimated glomerular filtration rate, which I'm just going to refer to as GFR from now on. They would give you an estimated GFR, and it would give you two different values. It would say, are they African American or are they Caucasian? Or African American, non-African American. They're actually not doing that anymore. You might still see it in labs that haven't updated their systems yet, but they're not differentiating glomerular filtration rate based on race anymore because they found that it's not as accurate as they once thought. So again, GFR, normal, about 130 milliliters per minute for men, 120 milliliters per minute for women, and that's assuming that they have a 1.73 square meter body. So if they're bigger, if they're smaller, then that number may change, but that's your baseline model patient. And again, variation based on size, sex, all those things we talked about. Cannot be measured directly in humans. The reason it can't be measured directly in humans is because the methods that you use to measure are invasive. So when they say it can be measured in animals, it's because they're doing invasive testing on them that you would never do on a human being. From the perspective of this is a good clinical test, the testing that's necessary to actually measure GFR is both invasive and expensive, which means it's not a good screening test. So in the past, did they do these things on human beings? Yes, they did, like in an inpatient setting, but it's not anything that we do as part of routine clinical practice anymore. Right? And again, creatinine is the most commonly used endogenous filtration marker in clinical practice because it's easy, it's cheap, and it's fast. What dictates GFR? Well, blood flow and glomerular surface area. So anything that affects glomerular flow, blood flow, whether that's hypovolemia, because the person is bleeding out, or they're in a shock, or they're taking medication to lower their blood pressure, is going to potentially have an impact on GFR. And then control of glomerular surface area. So anything that causes contraction of those structures. Or if they have lost glomerular surface area because they have intrinsic renal disease, then they're going to have an alteration in the GFR. Serum and creatinine clearance. So, like we talked about already, more muscle, more creatinine. Things like malnutrition causes decreased muscle mass, causes a decrease in serum creatinine levels. Creatinine clearance is the volume of blood plasma cleared in creatinine per unit of time. Okay. So, one common place where you might apply creatinine clearance is if you're giving somebody medication that needs to be dose modified based on the renal function. It will, if you read the nomogram for the medication, it will say for creatinine clearance of this range to this range, adjust the dose thusly. For this range to this range to this. If they're on dialysis, don't use this, or give it right before they have dialysis, something like that. So here's the most up-to-date formula for eGFR. You do not need to know this. You're not going to be asked to utilize this formula, at least not in this class. So don't worry about like trying to memorize the slide. But the bullet here at the bottom gets to what I was saying earlier. Reassessing inclusion of race in diagnosing kidney diseases concluded that race should not be included in GFR estimating equations and recommended the use of this 2021 CKD EVI creatinine equation that includes factors for age and sex, but not race group, because it was determined that this is more accurate. Okay. All right, creatinine levels can vary by age. Why do you think the normal creatinine range for cord blood is here, but newborns are here? What's the difference? I heard somebody say it. So immediately after delivery, a baby's creatinine level is reflective of mom's creatinine level, because mom's been responsible for their metabolism and digestion, basically, while they've been in the womb. And after a few days, outside of the womb, where they've normalized and taken over all those bodily functions on their own without support from mom, their creatinine is going to change. And then you can see what the normal levels are, roughly speaking. Obviously, there's some variation here, but as you go through life. And then, of course, 13 to 15, the reason there's a jump here, or why there's a cut here, is puberty, right? Okay, cystatin C. So this is probably the most commonly used lab now that sort of directly measures renal function. And all I'll say about it is that the reason it's not used more often is because it's expensive. You can order it. It's not like an uncommon test. It's not something that's like hard to get. If you're at a small facility, even if you're at a big facility, it may be a send out. So like BAMC doesn't do this on their own in-house. They send it out to lab. But like it says at the bottom, it's expensive. There are no questions on the exam about cystatin C. Just know that this is a way that you can actually measure somebody's renal function. If you have a reason to say, I need to actually know what's going on with this person's kidneys without confounding factors, without having to take into account the fact that this person bench presses 800 pounds, what is their actual renal function? Cystatin C is what you have. Okay, fractional excretion of sodium. This is important because if what the fractional excretion is can tell you whether or not the problem is an intrinsic renal problem or an extrinsic renal problem. So if you're trying to rule out an acute kidney injury, then looking at a patient's fractional excretion of sodium is helpful. And it's, like it says, most accurate when the patient is oliguric, not producing as much urine as they're supposed to, but you can do it anytime. Now, if you have somebody who is extremely well hydrated, like some of the people I saw doing urinalyses yesterday while I was a urinalysis observer, whose specimens were practically clear, their fractional excretion of sodium is probably not going to be a very accurate measurement because their urine is extremely dilute by artificial means. they're extremely well hydrated because they're trying to analysis. So, if their fractional excretion of sodium is less than 1%, so using this formula, plugging in their urine sodium, plasma creatinine, plasma sodium, urine creatinine, and running this formula, if your result is less than 1%, then they're probably hypovolemic or dehydrated. Something's going on from a volume standpoint. If it's greater than 1, particularly if it's greater than 3, then they have some sort of intrinsic renal disease. And again, what you're looking at is this person is not making as much urine as they should be based on the fluid that they're taking in. Is it because they're still fluid down? Do we need to hydrate them more? Or is it because their kidneys aren't doing what they're supposed to do? And we'll talk about this more like it says in the AKI lecture. Renal biopsy. Is this something you're going to do? No. Who does renal biopsies?
You?
Not urologists. So nephrologists do them, but also radiologists. And they don't necessarily have to be an interventional radiologist. There are radiologists that get trained in ultrasound-guided biopsies, and they'll do things like breast mass biopsies, kidney biopsies, anything that can be accessed under ultrasound guidance through the skin using a spring-loaded biopsy gun. But generally speaking, it's going to be your radiologists and your nephrologists that do kidney biopsies. Okay? And this is the way to really find out what's going on in somebody's kidneys. If you really want to know, do they have IgA nephropathy? Do they have whatever it is, post-infective glomerulonephritis? If you really want to know what's going on, you got to get tissue and you got to do immunoassay stains on it and look at it in the microscope, and that's how you get the tissue. Okay, any questions about the first section? About anything we've covered so far? Okay. We're going to do imaging modalities of the urinary tract. This will be relatively quick. Okay. Mostly it's so you just have an idea of what imaging modalities are available to look at the urinary tract and give you some idea of what imaging studies you should be using for given situations. And we will review all of the things that you need to know for the exam when we do the exam review. Okay? So, just generally speaking, in terms of cheapest and easiest to most expensive and most complicated, you're going to be talking about plain film X-rays, so just your regular old plain radiographs, like you'd go in for a chest X-ray or an X-ray of your arm. You suspect you have a broken bone, right? Plain radiographs. Plain radiographs can be augmented with IV dye. Then you're going to be talking about ultrasound, then CT, and then MRI. And within CT and MRI, you've got contrasted studies that look at things like the parenchyma, the meat of the tissue, or you may be looking at the vasculature. And then also you've got nuclear medicine studies, which we won't talk about very much because they're not really in the wheelhouse where they exist. Okay, so intravenous pylography. This is basically a KUB. Who can tell me what KUB stands for? Kidney, ureter, bladder. So it's an abdominal plain film that specifically is set up to make sure that they get the kidneys, the ureter, and the bladder. All KUBs are not IVPs, but all IVPs are KUBs. So the difference between a KUB and an IVP is the presence of IV contrast. To truly do a real IVP, you have to have a special table. They were tearing those tables out from the civilian hospitals that I rotated in as a resident when I was in training. So the likelihood that you're going to be able to get a real, true, honest-to-God IVP, the way it's supposed to be done anywhere these days, is slim to none. But if you have access to a plain old X-ray machine, so let's say you're in a Ford-deployed environment, you got a portable X-ray machine, and somehow you have access to IV dye, you can do an ad hoc IVP if you needed to. The reason you needed the table was it had a bump that would come up underneath the patient's back for when you would do the nephrogram phase, because it would bring the kidneys into focus. it would put everything else out of focus, but that was okay because what you were looking at was the kidneys. You were looking for renal masses. You were looking for defects in the contour of the kidney as the contrast with the kidney. And you can't actually do that without an IVD. But if you were doing just a KUB with contrast, then things that you could see would be the meat of the kidney starting to show up here, the parenchyma as the contrast is being filtered, and then you can see it starting to come out in the collecting system and drain down the ureters. Take my word for it, there's a filling defect here. Okay, this is something you learn from experience, just looking at lots of films. But you can see that there's a shadow here. So there's something in the collecting system that's keeping it from completely filling with contrast. So there's something there that needs to be evaluated, probably too. Renal ultrasonography. Who's ever had an ultrasound for any reason, kidney or otherwise? Okay. The great thing about ultrasound is that it is, especially nowadays, able to be done point of care. So you may have a handheld portable ultrasound that you've got access to that you can use for fast exams or anything else for that matter. You just have to have had some experience using it for those purposes. It's simple, it's non-invasive, it is now cheap, it didn't used to be. So when I was born and when my brother was born, we were both born at the Air Force Academy in an Air Force hospital. They did not routinely do prenatal ultrasound at that time because the technology was relatively new and it was expensive. By the time my sister was born, everybody was getting prenatal ultrasounds. So nowadays, it's cheap. You yourself can go online and buy a handheld ultrasound probe that attaches to your smartphone, and you can do ultrasounds yourself for about $2,000, which is a far cry from like the $50,000 that ultrasound machines cost, not too long ago. Right? And those things were the size of cabinets. There's no radiation, right? From ultrasonography, so it's safe. You don't have to worry about what cumulative lifetime dose am I subjecting this person to because I did an ultrasound. You don't have to worry about it, which you do if you order a CT. How many chest x-rays worth of radiation does a person get from a standard CT abdomen pulse? It's over 200. It's the equivalent of over 200 chest x-rays, which over the course of a person's lifetime is a lot if they get more than one CT scan. So something you have to be concerned about there. But ultrasound can show you the meat of the kidney. It can show you if they have a mass. It can show you if they have cysts. It can show you if they've got hydronephrosis or dilation in the collecting system. There's a lot you can glean from ultrasound, and you can use it for guiding a biopsy if you are somebody doing a biopsy. It is important to note that point of care ultrasound is not the same as a diagnostic ultrasound. You are not going to be as good with a point of care ultrasound as a formally trained ultrasound technician doing a formal ultrasound. If you really think somebody needs an ultrasound, order an ultrasound. But don't be afraid to put an ultrasound probe on somebody if you have access to one and you want to get a quick look. Like we talked about, easy to use, patients tolerate it well, it's non-invasive, there's no radiation. It is highly dependent on operator skill and the patient's body habits. If you've got somebody who's 1.5 HEV units here in San Antonio, they eat lots of tortillas, then you may not get very good imaging because the subcutaneous fat attenuates the ultrasound waves both in and out, so you may not get as good pictures. All right, so here's a normal kidney on the left. Here's an abnormal kidney on the right. I will tell you that the way you can tell just by looking at these two pictures is that the parenchyma of the kidney on the left is dark black. You can see a differentiation between the cortex, the medulla, and the renal sinus fat, and the one on the other side all looks like the same homogeneous stack. It's not supposed to look like that. You should be able to see a gradient between the different layers of tissue in the kidney from the medulla to the parenchyma to the collecting system and the renal sinus fat. Okay, again, normal kidney on the left, hydronephrotic kidneys on the right. The one on the bottom is really hydronephrotic. You can't hardly see the meat of the kidney around the rim there, right? It's so blown out. Hydronephrosis can be acute Meaning, like, if somebody has a kidney stone, they can end up getting dilation in their collecting system. But it can also be chronic. You can have somebody who was born with posterior urethral valves or bad vesicoureteral reflux, and it caused them to have bad hydronephrosis, and the underlying problem has been corrected, but the hydronephrosis never goes away. Think about a party balloon that you blow up for a party, and then it gets like blown behind a couch during the party, and you forget about it, and you don't know it's there, and you find it weeks later, and all the air's going out of it. Did it go back to the same size that it was when it came out of the bag when you first bought it? No. Kidneys are the same way. So if a kidney's been badly dilated for a long period of time, it may not go back to its original normal appearance. But if it's an acute problem like a kidney stone and they have hydronephrosis, then the hydronephrosis should go away after the obstruction is relieved. And then again, looking at the bladder, you can see the bladder very well on ultrasound. You see here that a radiologist has been here. They've left spore indicating their presence, bladder tumor. Is this really a bladder tumor? Don't know. You can't tell on ultrasound. All you know is that there's something in the bladder that's not supposed to be there, so it needs to be investigated further. But the point is, you know that there's something in here that's not supposed to be there. It could be an enlarged posterior median lobe of the prostate. We don't know the gender of the patient, so it's impossible to say in this picture. But it did show that there was something there that wasn't supposed to be there. Ultrasonography can also be used with Doppler to look for blood flow. So this is how you're going to determine whether or not somebody has a testicular torsion. So if somebody has signs and symptoms of torsion, which we'll talk about more in the urology section, what's the underlying problem?
Twisted.
The testicles have been twisted, and that has compromised what?
Blood flow.
The blood supply. Doppler will show you whether or not there's blood supply to the testicle. Now this is kidney, but that's how you're going to diagnose torsion is with ultrasound. And this is a transrectal ultrasound probe with a spring-loaded biopsy needle. So this person is undergoing a prostate biopsy to evaluate for prostate cancer. And in fact, this one is being done with MRI fusion, but that's way outside the scope of this. Okay, CT. You're going to order a lot of CTs in your career, more than likely, especially if you work in this urgency department. You're going to order a lot of CTs. So CTs can be done with contrast. They can be done without contrast. They can be done with and without contrast. It's very useful for imaging the kidneys for trauma. It is the gold standard for detecting renal stones. And like it says on the slide here, non-contrast. Why do you want to make sure that you don't use contrast if you're looking for a kidney stone? Say again? So right, the contrast shows up bright white. Kidney stones are dense. If they're radio-opaque, they're dense, like bone, so they're going to show bright white. So if you've got contrast in the system, you may mask the stone and not be able to see it. But you can see it's extremely sensitive and specific for stones if you do a non-contrast CT. CT urogram. This is what we're going to order, the urologist is going to order if you send us somebody with hematuria and we're doing a comprehensive evaluation for a urinary tract malignancy. A CT urogram is a 3-phase CT scan. So we do a phase of no contrast, a phase with contrast in the parenchymal phase where the contrast is basically the arterial system that lights up the internal organs, and then an excretory phase. So the radiation dose for CT urogram is high because they're getting a abdomen and pelvis CT 3 times in a row, all at one sitting. Also, they have to have normal renal function because you're giving but it's, like it says here, primarily we use it to evaluate hematuria as a source of potential malignancy. For renal masses, we're just going to do a CT of the abdomen with contrast. We're not going to put them through a 3-phase CT scan with, contrast and no contrast. If we want to know if they have a renal mass, we're just going to do a single CT scan with contrast. That is the gold standard for solid renal masses. Solid renal masses, CT scan with contrast, gold standard. MRI. Any MRIs that you all order are probably going to be for musculoskeletal complaints, probably. But MRI can be used to evaluate for urinary tract masses, particularly in patients who can't get CT dye for some reason, either they're allergic to it or kidney function's poor. Then you can do MR imaging for them. it's really used a lot for evaluation of the vasculature, which we'll talk about in just a second. If you do need to use contrast, it's gadolinium. So you don't have the same limitations with gadolinium. So if somebody has a CT contrast allergy, CT contrast and gadolinium are not the same thing. So you can do a gadolinium MRI, provided that they're capable of having an MRI, but they don't have a pacemaker or iron filings in their eyes because they work with an angle grinder with no eye protection on. But if they have poor renal function, then gadolinium is potentially bad news because they can end up with gadolinium deposited in their skin and elsewhere in their body. So that's what you see here is this systemic fibrosis in gadolinium. And then here, group 1, group 3 chart for you. This won't be on the test. Okay, radionuclide studies. Like I said, we're not going to talk about this much because we're not going to do it very much. I'll give you one specific example. There's something called a MAG3 Lasix renogram, which is a study that's done to evaluate for obstruction of the kidneys. Frequently in kids that have urinary reflux, a radionuclide is given IV, and then they're put in front of a radionuclide detector. What kind of detector depends on what kind of radionuclide study you're doing, but it can tell you depending on what study it is, it can tell you how well do your kidneys function. It can tell you how well do the kidneys drain, and just know that they exist. Know that radionuclide studies exist. You're not going to have any questions about them. Okay, arteriography and venography. In the old days, the only way to do arteriography or venography was percutaneously, right? Just like somebody would have a coronary angiogram and potentially angioplasty. If you wanted to look at the renal vasculature, you'd have to do the same thing. You'd have to gain access to either the femoral artery or the femoral vein, depending on which system you were intending to look at, whether system would be. Thread a catheter up, shoot contrast, take fluoroscopic images. Now, it can be done with non-invasive imaging in the form of CT scan and MRI. And we will talk more about renal artery stenosis and renovascular hypertension later. The point is just know that you can use these imaging studies to look for stenosis in the renal vasculature. So you can see the kidney shadows here, and you can see the vasculature supplying them, right? So here's your it's either the aorta or the vena cava, you can't really tell, and it doesn't tell you, and then iliacs. So here's a narrowing. So this is an arteriogram. We know that because it tells us that it's an arteriogram. And there's a notch here, and if you look very carefully, you can see there's actually a filling defect there. So there's something here that is keeping blood from getting to this kidney. And as a result, this patient probably has elevated blood pressure because they have renovascular, they have arterial stenosis, which is causing renovascular hypertension. So the characteristic presentation for these patients, and again, we'll talk about it more later, is you got somebody who's on like 3 or 4 drug antihypertensive therapy, and their blood pressure isn't getting any better. If you've got somebody who's on 4 agents and they're still hypertensive, look here, because this may be the source. So here's what CT angiography looks like. So what they do is they put somebody through a standard CT scan with contrast, take the pictures in the arterial phase, and then they use fancy computer software to do a 3D reconstruction of those images. So they take all the slices, put them back together again, the computer gives you a 3D image, you can spin it and turn it around and refresh your friends. But you can see here where the arrow, again, a radiologist has been present, you see their signs. There's a narrowing of the artery there. And then the same thing with MR. So this is what an MR angiogram is. And again, you can see here, there's no this isn't necessarily a contrasted study. It depends on the type of MRI weighting they're doing. Is it T1, is it T2, is it spin? Anyway, the blood is not lighting up here, which means that there is something keeping the lumen from being visible on the sun. And again, you can see it's very sensitive and specific. All right, retrograde urethograms. We're almost finished. So this is a plain film or fluoroscopic imaging study that can be used to evaluate for a urethral injury in males. We won't use this in females because the female urethra is only 3 to 4 centimeters long, and urethral injuries in females are extremely rare. The reason that they happen more in males is both the length of the urethra and the urethra, as it passes behind the pubic bone, is actually anchored to the pubic bone by a ligament. So if somebody suffers a pelvic injury that results in an open book fracture of pubic diastasis, that ligament can get yanked on and it can tear the urethra. So the top picture is a normal retrograde urethrogram. You can see the practitioner's hands here holding a Toomey syringe that has been inserted into the urethra, and they're pushing contrast in, and you see that the urethra has a normal course and the contrast gets up into the bladder. Here, it's a mess because the urethra has been disrupted and contrast as well. Okay. The characteristic sign that should make you concerned that somebody has a urethral injury and should have a retrograde urethrogram performed prior to trying to put the catheter in that patient is blood at the meatus. So if they have visible blood at the meatus, then they very likely have a urethral injury. Inability to void, perineal ecchymosis, these are also things that you can see, but in a question stem on, say, the pants or something like that, they're not going to just say perineal ecchymosis. They're going to tell you what it means. There's a sign. Don't put a catheter in the person. They're retrograde urethrogram. And then a cystogram is just a look at the bladder. Typically, if you're doing a plain film cystogram, you do place a catheter, fill the bladder with contrast, and then look at it under fluoroscopy or plain film. You can also do CT cystography. Generally speaking, you need to get at least 300 cc's of contrast into the bladder of an adult in order to get an accurate picture. Most of the time, if you're doing a cystogram, it's to make sure that they don't have a bladder injury, if they didn't rupture the bladder in, let's say, a car accident. And if you don't fill the bladder far enough, you may not necessarily see the leak. So 300 cc's is your cutoff. And then avoiding cystourethrogram is just where you put contrast into the bladder and then you take pictures while they're urinating the contrast out to look at the course of the ureter, to look at the urinary sphincters. Do they open the way that they're supposed to? Because you have an internal sphincter that's involuntary and an external sphincter that's voluntary and you can control. And they're both supposed to open when you urinate. Somebody's trying to urinate and the sphincters aren't opening, but they have a sphincter dyssynergia, and that's something that you can diagnose on avoiding cystourethrogram. It also looks for reflux in kids. If you suspect that a child has vesicovascular reflux. So what you can see in this picture is there's contrast actually going back up the ureter. That's what that shadow is right there. They're not leaking from the bladder. It's contrast actually going back up, which is not supposed to happen. And that is a very, very, very fast primer on imaging. I know it was fast. Don't worry about it. When we talk about the specific conditions that imaging is utilized for, we'll talk about it again. Okay. Was everybody able to access the slides for the first block, for the nephrology block? Okay. I hope to have the problem with the block 2 slides fixed today, so you should be able to access those.